For those of you who have been with us throughout the 2025 American Society for Radiation Oncology annual meeting, you know that Stephen and I have been busy bringing you the latest NRG-oncology trial results as they're presented. We heard high-profile results presented at the clinical trial session on Sunday on prostate cancer from several investigators, and at the ASTRO plenary session on Monday, we heard results of NRG-GU005 for prostate cancer and the RADCOMP trial for breast cancer. And today is our last day covering the late-breaking abstract session.
It's been an unusually busy ASTRO meeting for NRG oncology this year, with 6 studies roughly being presented in the major sessions like the plenary. As we close out our coverage of ASTRO 2025, I'm thrilled to bring my friend Dr. Benjamin Movsas on the podcast to speak about the results he presented on patient-reported outcomes in NRG oncology LU005 for limited stage small cell lung cancer. And regarding limited stage small cell lung cancer and LU005, you can also listen to our podcast last year covering the 2024 ASTRO annual meeting when we covered the primary results presented by Dr. Kristen Higgins. In fact, that podcast has been our most listened episode to date with well over 1,000 listens.
Dr. Benjamin Movsas is the medical director of Henry Ford Cancer Institute and chair of the radiation oncology department at Henry Ford Health in Detroit. With NRG Oncology, Dr. Movsas has been a pioneer in bringing patient-reported outcomes into the mainstream of cancer clinical trials and serves as the chair of the NRG Oncology Patient-Centered Outcomes Research Committee. Dr. Movsas, congratulations on presenting the patient-reported outcomes results of NRG Oncology LU005 at the late-breaking abstract session today. Before we get started, I know that you've been the chair of the ASTRO Scientific Planning Committee, so you are probably the perfect person to ask about this. Can you tell Stephen and I about what the late-breaking abstract session really is and how studies are selected for it and how that might be set apart in terms of this session compared to other sessions?
Sure. Well, first of all, thank you so much, Lauren and Stephen. It's really an honor to be here and have this opportunity to share about this late-breaking abstract. The late-breaking abstract is such a special session because, as we know, for a major scientific meeting like ASTRO, there's thousands of abstracts that get submitted for the meeting, and it takes months and months of preparations to have that peer review process and to go through selecting of the abstracts. And I think back to when I was in that role and just so many amazing volunteers that spend so many hours doing that important work. At the same time, it's really important to have a chance for those trials and analyses that mature closer to the meeting so that they can also be considered. And that's really where the late breaking abstract session comes in. To me, that was always kind of the most fun, was kind of to see kind of what was going to come through that process, and really very honored on behalf of NRG that this analysis was chosen for the late breaking session.
Before we get any further, I want to say for the record, for full disclosure, that I am a co-author of Dr. Moff's study, and I am a co-author on both the primary analysis of NRG LU005 as well as this patient-reported outcome analysis being presented today. Dr. Mofsis, in the primary analysis of LU005 presented by Dr. Higgins last year, the bottom line was that adding concurrent PD-L1 immunotherapy with atezolizumab to chemoradiation for limited stage small cell lung cancer just didn't work. Considering it was a negative study, or let's just say that's a fancy way of saying it didn't work when we say negative study, why is it important for us to be looking at patient-reported outcomes in these patients?
Yes, Stephen, that's a great question. And I think it's important to keep in mind that while the primary endpoint of this study was negative, there's still so much that we can learn from these secondary analyses, and particularly the patient-reported outcomes, because that really gives us the direct patient perspective. So, for example, even though there was no survival benefit, we may find other opportunities to combine this kind of immunotherapy with thoracic radiation in the future. And so it's important to understand what is the patient's quality of life from this kind of experience. And really, what this study was able to show us was that the patients overall did fine. They did not actually have any decrease in their quality of life as measured with a validated instrument. And in fact, later on in the study, their quality of life was actually slightly better on the immunotherapy arm. So to me, that's encouraging that even though in this particular setting, the primary endpoint was negative, that we can now understand that for future types of approaches, that this is still something that is tolerated, and patients are saying that their quality of life actually was fine on this type of regimen. Of course, there's a lot more that we can learn from this as well that we're going to discuss.
Even for Stephen and I, who are familiar with limited stage small cell lung cancer, chemoradiation, and even immune therapy, a lot of the terminology and tools used in patient reported outcomes investigations are a little bit of a foreign language. One of our goals on this podcast is to try to better explain medical and scientific jargon and break it down on a simpler level. Can you help us break down exactly what the FACT TOI, EQ5D5L, and promise fatigue measurements are that were used in this study?
Absolutely. That's a great point because we do use these abbreviations a lot. So, FACT TOI is a validated quality of life measure. And essentially, it stands for Functional Assessment of Cancer Therapy Trial Outcome Index. And essentially, it's an instrument that's been validated in lung cancer, which contains 21 items or questions, summing together functional well being, physical well being, and the lung cancer subscale. And again, this has been validated, sensitive. There's clinically meaningful changes that have been published in this regard. In terms of the promise fatigue, that is another validated instrument that is very abbreviated, 7 questions. It's based upon the NIH Patient Reported Outcomes Measurement Information System, or PROMIS, and it's a specific questionnaire that really focuses on fatigue that patients may be experiencing. And then the EQ5D5L is basically the most recent validated version of what's called EuroQol, which is a well-utilized instrument to measure general health status. And from that, you can actually look at different health states and get utility scores and start looking at issues like quality adjusted life years and so on. So really all very key patient-reported outcomes. And importantly, they're all very abbreviated. So for example, the 21 questions can literally be answered in about 5 to 6 minutes by patients. The PROMIS one in about 2 to 3 minutes, and the EuroQol, which has 5 questions, in about 2 to 3 minutes. So we're always very sensitized to the burden on the patients and making sure that we're using validated instruments that don't take up too much of their time.
With all that terminology out of the way, can you further elaborate on the results you presented today at the late breaking abstract session? What really stood out to you about these results? And was there anything that surprised you that you might not have anticipated?
Yeah, absolutely. As I mentioned before, our primary hypothesis for this study, our primary aim was really to see whether or not there was any impact on the quality of life by adding the immunotherapy to the chemoradiation in this setting. And we found that really there was no negative impact. The FACT TOI was actually pretty much the same in both arms, slightly better actually in the immunotherapy arm out at about 21 months after treatment. But essentially, like I said, no concern about a real decrement in that regard. The same, by the way, was true regarding fatigue. There are many reports saying that immunotherapy does increase fatigue. We found absolutely no change in fatigue from adding the immunotherapy. And likewise, there was no difference in the EQ5D quality adjusted survival analysis either. Really, I think what made this particular analysis interesting beyond what we initially set out to look at was, I think, another important issue, and that is, what about patients receiving twice daily radiation, BID, versus once a day? And this is an ongoing area of debate and discussion within our field for limited stage small cell lung cancer. In this study, this was not randomized for that factor, so that's something important to keep in mind. The investigators could choose whether to use the BID twice a day or the once a day. But what we were able to analyze and find was that the patients who received the twice daily radiation overall were reporting improved quality of life, relatively better FACT-TOI scores compared to the patients who were getting the once daily radiation. And this became quite prominent later on, out at about almost 2 years out from treatment. And so that was something that we definitely took note of, and something also that we wanted to put a lot of thought into the analysis because of the fact that it was not randomized to look at that specific issue.
So that's really interesting. I wanted to ask another question. When you mentioned that patients receiving immune therapy did not appear to have worse fatigue than the placebo, as I understand this study, we
Right.
often think of the placebo effect as being related to a patient experiencing a benefit. Is it possible here that some of the fatigue that patients are experiencing or toxicity, that these side effects are also a placebo effect?
Yeah, that's a really interesting question. For sure, placebos, as we know, has been well documented, can have this kind of positive effect on patients' outcomes. But I'd like to go back to the literature. It's a great question, Stephen, because I could imagine that it could likewise potentially have some negative impact as well, potentially based upon the patient's perceptions or what they might be expecting. So I think that's a great point, but I'm not aware of that. And, I think it's important to keep in mind that quality of life is something that obviously is based directly on the patient experience. But the more that we study quality of life, the more we find that it is actually a very robust measure. And like, for example, in this study at baseline, we had over 500 patients randomized. At baseline, the quality of life was essentially identical between the 250 patients on one arm and the 250 or so on the other arm, right? So you'd expect, like, oh, if it's just a subjective measure, maybe, one arm would be much higher or different than the other arm, but no. So it's interesting that there is, I think, something more objective about quality of life than sometimes we even initially think.
I want to call out again also one of the most interesting findings from LU005, in my opinion, that you just mentioned too, Dr. Mopsas, which was that radiation delivered twice daily was associated with better survival and more favorable quality of life than radiation delivered once daily. And if anybody's out there wondering why we call twice daily radiation BID, we use BID in medicine as a fancy abbreviation for bis and DA, which for those of you fluent in Latin, aka probably very few of you, you'll know that that means twice a day. And the reason that this is interesting to me is that two prior large randomized studies, namely the CONVERT study in Europe and the CALGB 30610 study, also known as RTOG 0538 in the United States, did not show that twice daily radiation was any different than once daily radiation. And I'm also intrigued by the quality of life being more favorable with that. I think physician perception has been that BID irradiation is maybe more of a hassle for patients or maybe has less quality of life. And I want to note that use of once daily or twice daily radiation in this trial that we're talking about, LU005, was not part of the randomization and was left up to the discretion of the treating physician. So, for that reason, how much can we definitively conclude about the impact of twice daily or BID radiation from LU005, especially when randomized trials didn't really corroborate this effect? Since coming in for radiation twice a day is perhaps logistically challenging for patients, or at least that's been our perception, is it possible that physicians intuitively selected patients who are healthier or maybe had better social support for twice daily radiation, which could explain potentially some of the survival and quality of life appearance of being better in LU005?
Lauren, your question really gets to the crux of the matter. So let's spend a few minutes and really try to kind of break down the different components of that really key question, because I really have to thank our NRG statisticians who really did a lot of work to try to sort out some of these important issues. So, for example, as you mentioned, the twice daily versus once daily regimens on this study, that was not randomized. The radiation schedule was not randomized. But when we looked at those patients that either got BID or once a day, and we looked at their quality of life at baseline, it was also almost identical, just like between the two randomized arms. The same thing here. Their performance status at baseline, essentially the same, similar age, TNM stage, and so on. There were some differences. For example, there were more males who received BID radiation than once daily. So first of all, our statisticians then did a very thorough multivariable analysis in which basically they went through and corrected for all of the other stratification factors, for any of these other factors that if there was any imbalance. And at the end of the day, not only was BID radiation, not only did it have an overall better quality of life than once a day overall, but even after there was this multivariable analysis to correct for these factors, it also still had a very meaningful improvement in quality of life compared to once a day. And I would like to also mention that we weren't just looking at statistical differences in quality of life, like a 1 point difference or something, that really did not interest us. We were looking for very well-defined, clinically meaningful differences in quality of life. And that's been published. So for FACT-TOI, you need to have a difference of 5 points. We also used each patient as his or her own baseline when we did this analysis. So for example, at almost 2 years after completion of chemoradiation, the patients who had once a day radiation, 40% of those patients had reported on their own a clinically meaningful decline in their quality of life compared to their own baseline. Compared on the twice daily patients, it was only 20% or so. So almost half of the patients reporting that level of clinically meaningful decline. And again, on the multivariable analysis, it also came out to be highly significant. So yes, I do think that when we look at this study, we need to keep in mind that it was not randomized for this, but I do think a lot of effort was put into thoughtfully trying to correct for that. And I just wanted to make one other, I think, important point here, and that is, you brought up about the convenience factor. And I do think that that is something that we do think about, obviously, when we think about twice daily versus once daily radiation. A couple of thoughts about that. Number one is that in that CLGB RTOG study that you mentioned, actually, they just recently published in Cancer this year their full paper on that. And it's fascinating that while they did overall say that the patients who had once daily radiation had, felt that it was overall more convenient. When you actually kind of drill down in more detail, when they looked at patients reporting what was very inconvenient, so not just somewhat inconvenient or somewhat convenient, but very inconvenient, 20% of the patients in their once daily arm said it was very inconvenient compared to 15% in the twice daily arm. And the other thing that they actually point out in their own paper is that just above 20% of the patients on the once daily arm did not complete their radiation, and almost 30% did not complete their chemotherapy. Whereas on the twice daily arm, the compliance actually ended up being quite a bit better, where almost 92% of the patients on the twice daily arm, we've completed their radiation dose, and 80% completed all 4 cycles of chemo. So when we say what's convenient, we also have to keep in mind how are patients actually able to complete their therapies as well. So I just think there's a lot here to digest, and these are all important points. I guess what I'm trying to learn from this analysis is we have twice daily radiation, we have once daily radiation. I think the CONVERT study and the CLGB-RTOG study did a great job really, comparing them in a randomized fashion. But as we know, their goal in both studies was actually to show the superiority of once daily over twice daily, and both studies failed to do so. And in both studies, in their papers, they actually come out and say that because of that, and they did not do a non-inferiority study, that they say the standard of care is still twice daily radiation. Now, we all know that there's some patients that once daily may be the best thing for those individual patients, but overall, both studies came out and said twice daily radiation still is the standard of care. So What I'm trying to understand now is if that's indeed the case, based upon those two studies, and of course, the older study, the Teresi study, then why is it that we're not using twice daily radiation more often, particularly in this country? And is one of the reasons that we're concerned that the quality of life may be inferior for those patients get twice daily radiation? And I think if that is indeed one of the concerns that providers have, I think this analysis helps to address that concern. I doesn't answer it definitively, but I think it does help because we're directly hearing from patients who 2 years later are saying, wait a minute, I took the BID radiation, I got it, and I can tell you that my quality of life was actually pretty good. And in fact, compared to the once daily radiation, if anything, it was better. So I think that to me really is an important message for us to at least hear what our patients are telling us.
This is all really fascinating information. And I will say that in my practice, where I see a fair amount of limited stage small cell lung cancer, that my default is to treat them twice daily for the reasons that you've talked about. In fact, I enrolled a number of patients on this trial LU005, and I was one of those physicians who selected twice daily radiotherapy for all of the ones I enrolled. So this really reaffirms some of my clinical decision making. Dr. Movsas, with all of our guests who we are bringing on the podcast presenting high profile results at ASTRO this year, we recognize that it is the product of a team of people. And I wanted to give you the opportunity to recognize important members of your team and collaborators. Who were the important people behind the scenes for this patient related outcomes analysis of LU005?
Well, first, one of them I'm actually speaking to, Stephen. You, as you mentioned, you're one of the co-authors, co-investigators, and you and the other co-authors, of course, deserve a lot of credit, not just for helping to accrue, but for helping to us to design this study, to bring it to fruition, and so on. One of my mentors for PROS is Dr. De Brunner, also very involved in that regard and very supportive. And of course, Dr. Higgins, who, as you mentioned, she is the PI of this study and was involved at every step and already presented the primary results. And the lead for the lung disease side at NRG, Dr. Jeff Bradley. I mean, these people deserve just an incredible amount of thanks and credit. I would like, though, to just take a moment and really also recognize our research associates in NRG. These are the individuals that actually go out and meet with the patients and encourage them to do their quality of life forms and make sure that there's compliance. And we can just not thank them enough for their dedication and support. Our compliance was actually higher in this lung study than in prior NRG lung studies, which is very impressive and very important. And ultimately, I mean, the real thanks goes to our patients, because let's face it, it does take more time to fill out these forms, whether you're doing it, an e-form or however you're filling it out, right? It takes a commitment, it takes a dedication for a patient to take the time to tell us what they're experiencing and to be able to benefit the next group of patients. So we really owe them a huge debt of gratitude.
Dr. Movsas, as I understand it, after a long run as the chair of the Energy Oncology Patient Centered Outcomes Research Committee, you plan to transition out of this role next year. Can you remind me how long you've been at this and speak about some of the highlights of your tenure? And what does the future hold for the Patient Centered Outcomes Research Committee?
Sure. Thanks, Lauren. It's been a huge honor for me to be in this role for NRG, and it's hard to believe it's been about 12 plus years now. So my term is coming to an end. I think each term is 6 years, and they let you do 2 terms. So but I'm going to obviously be staying very involved and so on. I was involved even before as part of RTOG in this, and I really kind of all got started many years ago, and I think I still remember my dad of blessed memory, who was himself a surgeon and a very, skilled and compassionate surgeon. And when I was starting medical school, he kind of took me aside and said to me something that I'll never forget. And he said, Ben, make sure as a physician to be humble and to always listen to your patients. And somehow that's always stuck with me. And to me, this ability to enable our patients to fill out these PROs, patient reported outcomes, is really a way ultimately to hear their voice. And to me, that's really what it's all about. And this, late breaking abstract is just one example, but really probably the thing that I'm most proud of over the years is helping to make PROs more mainstream. I remember back, this is going back a few, 2, 3 decades, you would talk about quality of life, and a lot of well-intentioned oncologists would say that's kind of soft science. It's not that objective. And now over the years, I think we've been able to show that no, actually, it's based on science. These are validated instruments with reliability and responsiveness and publications. And now we have the opposite wonderful challenge within the NRG Core Committee, where every study, somebody wants to add quality of life to it. And we have to really go back to the investigators and say, that's great, but what's your hypothesis? What are you trying to study scientifically? This is no different than any other scientific endpoint, and we need the same rigor. So I think to me, that's really been huge. And, when we see abstracts like this to be part of the ASTRO late breaking session, and we've had previous NRG quality of life abstracts in the plenary, and we put a lot of effort as much as we can to publish the primary endpoint paper side by side with the PRO paper. It starts realizing to me that this is making a difference. And, just a couple of brief examples over the years, right? We've been able to show that PROs are probably one of the most powerful independent prognostic factors in 0617, even back to RTOG 9801, these lung studies. We actually found that quality of life superseded all these other, classic prognosticators like stage and weight loss and things like that. Is this really powerful? And then we've had that kind of these newer discoveries like in 0617, and Stephen did a great job showing why IMRT was important. And then from the standpoint of clinical toxicities. And then when we looked at it in terms of quality of life, it also stood out as IMRT having a real benefit for patients in terms of their own quality of life compared to 3D. And the quality of life that we've done over the years has helped us guide future studies. Like, for example, the work that we did in the RTOG, NRG, PCI, prophylactic cranial radiation studies for lung cancer, right? We showed that there are these real neurocognitive effects that really impact patients. And now that's led to intervention studies, right? That whether it be memantine, hippocampal avoidance, these are really novel strategies. What did they come out of? They came out of our patient's voice telling us that what we were doing wasn't good enough. We needed to do better for them. And to me, that's really what it's been all about. And it's been a real honor to be part of that. And when I look to the future, I'm just so excited because, I think about how we can do more interventional studies with PROs as the primary endpoint or a co-primary endpoint. And we're already doing quite a bit of that as part of the NRG NCORP group, working with Dr. Bruno and so on. We just actually had a very interesting analysis with Dr. Ben Korn looking at hope as a cognitive construct and showed that that actually correlates very much so with patients' quality of life. Just a few examples, but I guess I want to at least mention briefly that when I think about the field of patient-reported outcomes in general, and even beyond clinical trials, to me, this is moving into the clinic. That we're finding, and there's now studies that show by having real-time PROs in your clinic and using it as a kind of vital sign, you can actually improve the patient's quality of life in real time. You can even improve their survival based upon some randomized data. It's pretty amazing. So at Henry Ford Health, we've decided to do that. And now we have moved every cancer patient, no matter where they're coming into our system, is offered the opportunity through the electronic medical record to actually put in their validated PROs. If there's a concern that comes out of that, it gets automatically sent to our urgent care Oncostat cancer clinic, and they look at it, they contact the patient, they have algorithms, and they send this patient to psych onc and that patient to the cancer pain team. And to me, this is the future, and clinical trials helped us get to this point. But I think ultimately this is really so critical because this is ultimately how we can really help our patients day in and day out. And so, yeah, very exciting.
Today we had Dr. Benjamin Mofsas speaking about the results of the patient-reported outcomes analysis of NRG-LU005. Dr. Mofsas has been the long-standing chair of the Patient-Reported Outcomes Research Committee with NRG Oncology, and as I like to think about it, has been a pioneer and a luminary in understanding how to better understand patient reported outcomes so that in our quest to cure more patients of their cancer, we aren't scorching the earth. Dr. Mofsas, thanks again for joining the NRG Oncology podcast and for your years of distinguished service to NRG Oncology.
Thank you so much. Really appreciate the opportunity. And as I like to say, let's continue to proceed with pros. And really appreciate Lauren and Stephen, what you do for NRG. These podcasts are really amazing. Just a really great opportunity to share with people kind of what's on people's minds, and really appreciate it.
Next up for this podcast episode on the 2025 ASTRO late breaking session, we are joined by Dr. Mehta, who is chair of the NRG Oncology Brain Tumor Core Committee and presented results of NRG-BN001. Currently, Dr. Mehta is Chief of Radiation Oncology, Deputy Director, and the John and Mary Lou Dosberg Endowed Chair in Radiation Oncology at Baptist Health Miami Cancer Institute in Florida. As a refresher, NRG-BN001 is a clinical trial for glioblastoma multiforme, often abbreviated as GBN. Glioblastomas are a major challenge clinically, and there have been a number of high-profile public figures who have died from this cancer, like the late John McCain, Ted Kennedy, and Beau Biden.
Other notable figures who have succumbed to glioblastoma have included the MD Anderson president, Dr. John Mendelsohn, composer George Gershwin, who wrote Rhapsody in Blue. Some of you might know this as the song that they play with the safety video on United Airlines, and the comedian Tim Conway. Despite glioblastoma being the most common cancer originating in the brain, glioblastoma is a tough tumor to treat, with very few long-term survivors despite aggressive surgical removal, followed by chemoradiation and consolidative chemotherapy. Our best efforts tend to just slow these tumors from coming back exactly where they originated. And it's for this reason BN001 was developed to test whether increasing radiation doses to tumors using a simultaneous integrated boost technique to a dose of 75 gray works better than the historic dose of 60 gray in combination with the standard chemotherapy for glioblastoma, temozolomide. Dr. Mehta, welcome to the podcast. To start off, can you go over with our audience what exactly a simultaneous integrated boost is and how BN001 was designed to demonstrate its potential impact?
Thank you so much for giving me this opportunity to be on this podcast. On behalf of all my investigators on BN001, it's a pleasure to talk about the results of this trial. As you alluded to, this trial tested the concept of simultaneous integrated boost. This strategy allows the boosting of a subvolume of a tumor without extending the overall time during which the totality of the radiation therapy is delivered. There are really two biological reasons to do this. The first is the obvious one, dose escalation, but the second is to reduce the impact of accelerated repopulation that occurs in tumors as we begin to irradiate these tumors. And therefore, if we take longer and longer to give a higher and higher dose, the overall efficacy diminishes. Simultaneous integrated boost is one mechanism to overcome this negative impact of accelerated repopulation.
This hasn't been the first time that data from BN001 has been reported. Dr. Mehta, can you remind us what results were presented before from BN001 from the X-ray or photon arm of the trial?
Dr. Henke, thank you for that question. You are indeed correct that this is the second presentation from this phase 2 randomized trial. The trial was designed to compare standard of care 60 gray against 75 gray simultaneous integrated boost. Institutions could declare themselves as proton or photon institutions. Photon institutions would treat with 75 gray using photon therapy, and proton institutions would do the same using proton therapy. The photon component of this trial completed accrual much faster, as would be expected and as was anticipated at the time of trial design, given the significantly larger number of sites with access to proton therapy. Therefore, these results had the required event rate that occurred earlier, and those data were previously presented at ASTRO. The concept behind that particular arm was to test purely the simultaneous integrated boost dose escalation hypothesis to try and determine if the IMRT cohort would demonstrate improved overall survival. The p-value in that particular cohort comparison was 0.25 and therefore did not reach the prescribed threshold to provide an impetus to move forward. There was no statistically significant or clinically significant difference in overall survival between 60 gray and 75 gray simultaneous integrated boost using photon radiotherapy, and therefore that particular arm would not be moved forward into a definitive phase 3 trial.
Thanks, Dr. Mehta, for this background. And with this background in mind, could you fill us in on what was presented today from the proton arm of BN001 at the ASTRO late-breaking abstract session? And can you also talk about the physical differences between photons and protons for glioblastoma that might explain why the results were different than the previously reported photon arm? I know we've had people on this podcast in the past talk about the physical differences of protons and photons for things like hepatocellular carcinoma with Dr. Ted Hong, but if you could just fill us in specifically what's different here and why do you think that the results were so different between these two arms?
Dr. Chen, thank you for that very insightful question. That question actually goes to the second hypothesis that was embedded within this trial. As I mentioned earlier, the first hypothesis was a simple dose escalation hypothesis, and therein we failed to show a benefit with photon radiation. However, the second hypothesis that was built into this trial was the emerging recognition that lymphocytes are critically significant in anti-cancer therapeutic outcomes for almost all therapies that we expose our patients to. For long, there have been a significant number of observations that have determined that radiation therapy, especially the low-dose bath that is consequential to photon radiation, induces lymphopenia in many, many clinical settings. In the context of glioblastoma, it is now well understood that of the multiple factors that induce lymphopenia, radiotherapy, the low-dose volumes, is a critical factor. In fact, there are data that are demonstrating that the volume of brain exposed to 25 gray or more could predict the extent of acute severe lymphopenia. We now have randomized data from photon versus proton trials demonstrating in the context of the brain that less volume of brain exposed to low-dose radiation with protons results in lower rates of acute severe lymphopenia. And we have indirect data that clearly demonstrate that patients whose CD4 counts drop lower seem to have inferior survival. So this whole hypothesis suggests that proton radiotherapy might potentially enhance survival, not through the physical properties of the proton beam, the Bragg peak per se, but really the subsequent biological impact of decreasing the low dose volume, therefore resulting in lower rates of lymphopenia, and putatively, therefore working with the immune system to improve outcomes in patients. And this was the second embedded hypothesis that we tested in this trial, and the results of that were reported out. Perhaps briefly, I could mention the results. We had a total of 193 patients that were randomized. It was a 2-to-1 randomization. 116 patients received dose-intensified simultaneous integrated boost proton therapy, and 77 patients received standard dose 60 gray radiation. The patients were well balanced in terms of patient characteristics, although we did see proportionately more unmethylated patients on the proton arm and proportionately fewer patients with gross total resection on the proton 75 gray arm. The toxicities were statistically not significantly different between 60 gray and 75 gray proton therapy. But interestingly, the grade 3 lymphopenia rates were numerically higher with 60 gray photon radiation compared to 75 gray proton therapy. In terms of the primary endpoint of the study, please remember that this was a signal-seeking phase 2 randomized trial because we were really looking for whether one arm or the other, i.e. photon or proton 75 gray, would prolong survival, and therefore the statistical thresholds were set in the context of phase 2 trials and not a definitive phase 3 randomized trial. The alpha for the study preset statistically was 0.15, and what we observed was a p-value of 0.11, so lower than the preset alpha. The hazard ratio was 0.81 in favor of the proton arm, resulting in a 2 and 3 year overall survival of 49.9 versus 43.1% for 2 years, and at 3 years, 30 versus 25.4%, resulting in 2 and 3 year deltas of approximately 7 and 5% for overall survival in favor of the proton arm. This was the overall observation, and clearly this observation is within the statistical hypothesis predefined within the trial, and therefore merits further consideration in terms of a phase 3 randomized trial to establish whether this would genuinely prolong survival in glioblastoma patients.
So I just want to re-highlight what you were just saying, and this may seem like some to kind of be obscure statistical considerations, as many of us in medicine are used to p-values being less than 0.05 being significant for us to draw conclusions about a finding in a study. And for audience members potentially unfamiliar with biostatistics, a p-value is the probability that differences between two groups is due to chance. So if someone says that the p-value is less than 0.05, it means that there's a less than 5% likelihood that different results can be explained by chance or by random error. And it's usually this 5% threshold where we feel comfortable in claiming that an intervention's effect wasn't just due to chance, but as you've just pointed out, in this study we settled on a p-value of less than 0.15 to draw potential conclusion that there might be benefit for the proton 75 gray arm. And as you said, this is really intended to be signal finding to understand if there was potentially a difference, perhaps, with photons and protons to carry it forward. So I guess a question that's top on my mind now after these results is, what will it take to routinely adopt dose-escalated proton therapy for glioblastoma? What's next?
Dr. Henke, you bring out an extremely important trial design element that needs to be reemphasized. The data that we are presenting were clearly designed and developed to demonstrate a signal. This was, from the very beginning, a signal-seeking trial, and one way to think about this is to think about what is often referred to as a pick-the-winner strategy. In other words, one identifies a predefined threshold that a therapy has to beat, and if a particular therapy, one or more therapies, beats that particular threshold, that arm then graduates to definitive testing in a properly conducted phase 3 randomized trial. In the context of BN001, the two arms were proton and photon 75 gray simultaneous integrated boost. Unfortunately, the photon arm did not graduate to the statistically predefined level, but the proton arm indeed did. That does not mean that we can conclude that we have level 1 evidence that proton therapy improves overall survival in glioblastoma. What we can conclude is that the predefined signal barrier or the signal boundary for proceeding to a definitive trial has been met. The next step is indeed to conduct a definitive clinical trial to demonstrate whether this survival benefit is meaningful and can be demonstrated in a properly conducted phase 3 trial with the appropriate p-values as you mentioned. In parallel with this trial, a number of new developments have occurred in the field where the identification of the area that needs to be boosted can potentially and putatively be enhanced using advanced imaging. Within NRG oncology, we are in the process of developing such advanced imaging therapeutically guided boost strategies, and perhaps combining 75 gray proton simultaneous integrated boost as a nested question with advanced sophisticated imaging as a biomarker for identifying the target would represent the next frontier for phase 3 testing.
One question I also wonder about is, as we alluded to at the beginning of our discussion, the landscape for glioblastoma treatment is often somewhat bleak if you're facing it from the patient perspective. Do you think that there will be appeal to adopting the results of this study as a treatment option for patients before a phase 3 trial can be run? How much of a problem do you think that may pose, or is that something that patients should rightfully want to consider now?
Dr. Henke, you bring up an extremely important yet difficult question to answer. Because the outcome of this disease is so grim, patients do seek every opportunity where even the slightest advantage could be garnered. And so I have little doubt that there will be some patients and there will be some clinicians that view the results that we present here as sufficient to start offering proton therapy off trial as a standard of care with a 75 gray simultaneous integrated boost as an option to patients with glioblastoma. I hope that that happens infrequently, and I hope that that does not become a routine thing because we clearly have the responsibility of generating high level data to support that decision.
I have
One,
to agree, Dr. Mehta, especially with dose escalation. We've learned the hard way from a number of trials in radiation oncology. I treat a lot of lung cancer patients, and we had great phase 2 data for dose escalation for locally advanced lung cancer. And then when we conducted the trial RTOG-0617, escalating to 74 gray, not only did not improve survival, that was actually detrimental to survival. So I agree that it's very important for us to interpret the trial for what it is and not try to go outside of what it was intended to do.
absolutely in total agreement with you, Dr. Chen. I think this is a very important recognition and observation that dose escalation is not a freebie. There is the potential for toxicity with dose escalation. And so it should not be assumed to be routine, safe, or standard of care.
Speaking of the importance of phase 3 data, one thing I didn't see mentioned so much today with BN001 is an intervention for glioblastoma for which there is level 1 evidence from a randomized phase 3 trial, with this intervention being the use of tumor treating fields. Tumor treating fields are low frequency alternating electrical fields placed on the skin, which about a decade ago were shown to actually improve overall survival for glioblastoma. But there's been a lot of variability in the adoption of tumor treating fields. Dr. Mehta, can you elaborate on the role of tumor treating fields for glioblastoma? And did BN001 encourage or account for the use of tumor treating fields in its design?
So tumor treating fields is now an FDA approved standard of care therapy for patients with both newly diagnosed and recurrent glioblastoma. In particular, in the newly diagnosed context, we have randomized clinical trial data that show a significant improvement clinically and statistically in overall survival in favor of TT fields. This is typically applied after completion of the chemoradiotherapy phase, i.e., in the adjuvant setting. Although results of a trial using tumor treating fields with radiation, i.e., in the concurrent setting, will soon become available and are keenly awaited. But at least as of now, it is used in the adjuvant setting. This is a standard of care approach that is available for these patients. When BN001 was designed, the data for tumor treating fields were not available. The results were not there. We did not have any mature identification of a survival benefit. And therefore, tumor treating field utilization was not incorporated or encouraged within BN001. There were probably very, very, very few patients on BN001 that received tumor treating fields in the context of pre-recurrent disease. I'm quite certain that some patients probably received tumor treating fields at progression or at relapse. But again, in totality, that number was probably small. So these data should probably be viewed in the context that the data that we are looking at mostly reflect the lack of use of tumor treating fields. Is it possible that the utilization of tumor treating fields with proton therapy, assuming that the hypothesis of sparing lymphocytes is what's driving the benefit of proton therapy, might be more than additive? We've recently had the results of the LUNAR trial in lung cancer and the results of the METIS trial in lung cancer brain metastases, both using tumor treating fields presented. And both of these data sets show that in patients receiving immune checkpoint inhibitor therapy, the impact of tumor treating fields is enhanced, implying that the overall totality of the impact of tumor treating fields is also enhanced when the immune system is more intact than less intact. And therefore, that's an intriguing hypothesis. And therefore, in a future trial where we test the value of proton therapy, tumor treating fields will be incorporated as routine.
Well, Dr. Mehta, thanks again for joining us on the NRG Oncology podcast today. Congratulations on these late-breaking results, and we look forward to that bigger phase 3 clinical trial coming out of the NRG Oncology Brain Tumor Core Committee.
It's a pleasure. Thank you so much.
To close out a very busy ASTRO 2025 for us at NRG Oncology, we've invited Dr. Stephen Frank to discuss a couple of tantalizing NRG trials on proton therapy that were presented this year. Dr. Frank has served as director of the MD Anderson Proton Center and is currently the executive director of the MD Anderson Particle Therapy Institute. Having led a large randomized clinical trial comparing protons and conventional X-ray based photon therapy for head and neck cancer, I thought it'd be useful to get his take on the results of the RADCOM trial for breast cancer presented by Dr. Shannon McDonald at the plenary session and BN001 just presented by Dr. Mehta at the late breaking abstract session. Dr. Frank, welcome to the NRG Oncology podcast. First off, we heard that patients subjectively seemed to prefer protons for locally advanced breast cancer in RADCOM, and there also seems to be at least a suggestion that dose-escalated proton therapy has a survival benefit for glioblastoma. Could you, in very broad terms, tell us your take on these results and how doctors should be talking to the patients about these findings?
Well, Dr. Chun, first, thank you for having me and giving me the opportunity to participate on this excellent podcast and really helping understand the implications of some of these large randomized trials that are very difficult to run. Randomized trials in proton therapy are complicated and very exciting when they are starting to accrue, like the breast study is done with Dr. McDonald and also with Dr. Mehta. So they should be congratulated on completing these trials. I think it's very exciting to see some of the initial results coming out of RADCOM. Starting to see some of the early quality of life data is very telling. It's interesting to see that first proton therapy has done as well as the conventional radiation in many of the quality of life, but to see that patients are preferring protons over conventional radiation in these quality of life instruments is interesting in multiple ways. It helps us better try to understand, is there something unique about their delivery, their care, and their quality of life that we can tease out? And I think Dr. McDonald is trying to better give that level of information in this particular study. We're also seeing that there's potential benefits in terms of the quality of life. And I think we'll be able to tease some more of this data out in long-term outcomes and follow-up. This is a long trial that is going to take time to continue to gather data, but this is the first evidence in a level 1 phase 3 trial showing some of this data and this quality of life data. So I think it's very exciting to see some of this outcome data from breast cancer patients. Some of the things that we want to understand a little bit more and we're trying to gather is this unique to patients with left-sided breast cancer where they're exposed and have principal exposure to the heart? And that's an area that potentially has some benefit in terms of the primary endpoint of major cardiovascular events. So I think this is a nice initial report with some good information that is going to continue to evolve and provide us much richer data for patients down the road. I think what's equally and probably more exciting is some of the survival benefit that we're seeing with dose intensification in glioblastoma with proton therapy. The initial study with Dr. Mehta and BN001 looking at photons has not shown a survival benefit. So what is it unique about proton therapy? Is it a biologic? Is it the physics properties of eliminating unnecessary radiation? Is it the lymphopenia associated with perhaps some T cell exhaustion that may occur. These are some things that are difficult to determine at this present moment, but is exciting to gather some more information and where this is going. We've seen another randomized trial, the oropharynx trial, which is a cooperative group study, but it also shows less lymphopenia and in a survival benefit improving over 5 years. So there may be something that we're starting to evolve and seeing that may be associated with lymphopenia reduction that is associated with improvements by utilizing proton therapy. So I think we're starting to see some trends in different opportunities for proton therapy to continue to add benefits to certain patients.
As discussed by both Dr. McDonald and Dr. Mehta, despite promising results, it's still not quite enough to be routinely offering protons as standard of care for either locally advanced breast cancer or glioblastoma. You've been at the forefront of designing proton trials and advocating for protons in the health policy arena. In your opinion, what more do we need to do to meet the bar to routinely offer protons for things like breast cancer or glioblastoma? How do trials need to be designed so we can get the routine indication for the use of this technology for our patients?
This is an important question. And one of the things that I think is continually important to do is to identify the right group of patients that may benefit from this unique and important technology. Proton therapy has unique biologic properties, unique physics properties, different from photon therapy. And so, as we think about how to utilize this technology, we need to identify the right patients and we need to identify the right endpoints that can measure differences. And so, I think that both of these particular studies are trying to look at the right type of patients who can provide a benefit. Patients, again, with left sided breast cancer, where the chest wall is immediately adjacent to the LAD or the left descending artery, where you're really worried about potential cardiovascular risk with radiation therapy. And what we've seen is even very low doses to these cardiovascular structures can have profound impact onto long-term survival in women. And so I think the study is looking at the right approach and right events. And I think we need to have the level 1 evidence to really push these opportunities for proton therapy. When we look at the BN001, this provides a great opportunity to identify that right patient as well, who then you can run a phase 3 trial to further gather more evidence. The proton community and the entire radiation oncology community and NRG are moving to do these trials in a very methodical way. We need to continue to run more studies with very highly well-defined endpoints. Will patient-reported outcomes be enough? Is survival the critical endpoint? Is progression with local regional control the most important endpoint? Or is CTCAE toxicity the most important endpoints? We also have to ask patients. When we design these studies, we need to have a patient advocacy group intertwined in the design of these trials, because patients also have the opportunity and we need to be listening to what outcomes that they consider to be important. And I think through that collaboration, we can then design the most appropriate endpoints for patients in these trials.
One thing that you've alluded to is that one of the real hurdles that we encounter with proton therapy is that protons, no doubt, are more expensive than conventional X ray based radiation. And while there are certainly disease sites and populations where we can justify the use of protons without randomized data, I get the sense that even without randomized trials, third party payers would allow proton therapy if the cost of proton therapy were the same or even less than photons. So, on one hand, conducting large clinical trials and testing protons is certainly a strategy to prove the value of protons. On the other hand, I wonder, is there a pathway to reduce the capital costs of building and operating proton facilities? And with that in mind, what is your take on the implications of the proposed radiation oncology case rate or the ROCKER program for proton therapy that has been discussed at length during this ASTRO meeting?
These are some very important questions on the health policy side. And, we've done several studies looking at health policy implications by working with the University of Texas system and Blue Cross Blue Shield. And we actually did a study where we took patients with different disease sites, whether it was breast cancer, head and neck cancer, lung, and we were able to demonstrate with treating those particular patients and then looking at the cost of care of treating those patients that we actually reduced healthcare cost for the UT system. And through that particular study, we were able to allow for proton therapy to then be approved, even though it cost more, because patients had less cost in terms of hospital admissions. And we published on that data. And I think that was a very effective way to demonstrate the value. With all that being said, it does cost more to operate and run a proton center than a conventional center. It is a different type of radiation modality, eliminating unnecessary radiation that would provide justification for a higher reimbursement than conventional radiation. So aligning and fixed pricing different radiation modalities may actually not be in the best interest of proton therapy and radiation oncology. And I recognize that what we can try to do is to decrease the expense and the cost of the systems. And we are having lower cost proton therapy systems coming out. We now have the ability to have gantry-less systems in a chair, but those are early and we're starting to learn how to use those systems, and they're not fully within the infrastructure of all of the healthcare systems today. But that is one way to reduce overall cost. Case rates are a model being developed right now, especially when we move into hypofractionation, but physicians are still putting in the same amount of work in order to take care of these patients and yet getting reimbursed less. And so case rates may make a lot of sense. So I think we need to look at these models. We need to understand what the costs are to run these centers and appreciate that if it takes more cost to take care of our patients with proton therapy, then a different reimbursement structure needs to be considered.
Well, Dr. Frank, I'd like to thank you again for all of your perspectives and experience and joining us on the NRG Oncology podcast today to discuss results of RADComp and BN001 at the 2025 ASTRO annual meeting.
Thank you for having me. It's been great to be on your podcast, Stephen, and I look forward to having the opportunity of speaking with you more in the future. Thank you.
In this special episode of the NRG Oncology podcast for the ASTRO late breaking abstract session, we heard from Dr. Benjamin Movsas on patient reported outcomes for limited stage small cell in LU005, Dr. Mehta on the proton arm of BN001, and finally Dr. Stephen Frank discussing the implications of these NRG Oncology proton trials presented at ASTRO this year. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for tuning in, and happy clinical trials.